G'day, I'm Bruce Campbell. It's a great pleasure to be talking to you about intravenous thrombolytics in the extended time window. I have no disclosures. I'm going to be talking about the evidence for thrombolytics beyond 4.5 hours, both with non-contrast CT, perfusion mismatch, and up to 24 hours. I'll talk about tenecteplase and alteplase, and I'll talk a little bit about the use of intravenous thrombolytics before endovascular thrombectomy. Also talk about the practicalities and the role of perfusion imaging more generally in suspected stroke and specifically for lytics beyond 4.5 hours. So we know that a lot of the patients we see present beyond 4.5 hours, probably the majority in fact, or have an unknown onset. And when we look at the original thrombolysis alteplase versus placebo trials that were meta-analysed by Emberson et al. In The Lancet in 2014, you can see that the 4.5 to 6 hour window did not show a benefit of alteplase in those patients who were selected using just a non-contrast CT to exclude hemorrhage. The TWIST trial was in Norway using tenecteplase. It showed a trend for benefit of tenecteplase versus placebo in patients who had woken up with stroke and were within 4.5 hours of their waking up with symptoms. But it was not significant. That may have been underpowered, but it also indicates that that selection paradigm was not successful on its own, even in the early wake-up phase. Perfusion mismatch and flare diffusion mismatch are the proven paradigms, which I'll talk about in more detail. The non-contrast CT is, however, really important for safety, and I emphasize that a number of times. If you have non-contrast CT hypodensity, then that is a concern for bleeding, and we'll talk about the combination of lytics and EVT where the evidence is a little less clear. So here is the Emberson meta-analysis, and you can see that very strong time is brain interaction there. And this was just using non-contrast CT to exclude bleeding. Why is that time effect there? Well, it's partly that the salvageable penumbra is converted to ischemic core over time. It's partly that the intensity of injury to the blood-brain barrier and therefore the risk goes up, although it's actually not a significant interaction between time and the risk of symptomatic intracerebral hemorrhage, interestingly enough. And there's probably also an effect that as time passes, the clot becomes less susceptible to the fibrinolytic medication that we're giving. So here is again that Emberson done by time, and you can see that although the point estimate is in favour of alteplase, it wasn't statistically significant with, 2,000 over 2,000 patients in that group. So there is no benefit of alteplase versus placebo, or for that matter, T&K versus control in that extended time window. There's the TWIST data, as I mentioned, showing a non-significant, again, favourable point estimate, but nowhere near statistical significance for benefit beyond 4.5 hours. And that was a group with good favourable non-contrast CT within 4.5 hours of discovery of wake-up stroke. So selection for intravenous thrombolytics is important to note that if you don't have a vessel occlusion, it's actually very difficult to show a benefit of alteplase versus placebo. So having some sort of vessel occlusion makes life a lot easier when you're trying to demonstrate a benefit of thrombolytics. And here is the original penumbral hypothesis published in 1977, where if you lower blood flow, there's a point at which electrical function ceases, and then below that you have to drop quite a bit more before you get irreversible damage to the neurons and other cells. So if you put that in practical terms, you block the MCA, that lenticulostriate territory doesn't have collateral supply and therefore will die fairly rapidly. Much of the rest of that territory may get anterior or posterior cerebral artery leptomeningeal collateralization, very variable between individuals, and so the ischemic core will tend to grow as those collaterals fail over time. The patient looks the same at this stage as they did when it was salvageable, but of course we've missed the opportunity to treat the patient. So that is why there is a relationship between time and the amount of salvageable tissue, and we can image that with perfusion imaging, and CT perfusion being the most practically applicable. So in CTP, we operationalize the core, the irreversibly ischemic injury, as severely reduced cerebral blood flow, and less than 30% of normal brain is the threshold that most of the software uses. Now, that does have some variability with time to reperfusion and between grey and white matter, which we can talk about, but in general, it gives you a pretty good estimate of what's likely to be irreversibly injured at the time of scan. We then use a delay threshold like Tmax greater than 6 seconds to identify the tissue that's at risk. risk, and this is the symptomatic territory. It's a territory supplied by collaterals, and you can see, that you can estimate this patient with a very small core in the basal ganglia and a large penumbral region in the cortex. Their aphasia and inattention and right hemiparesis will get better if you open the artery quickly. So penumbral imaging has a number of uses. In diagnosis, it's helpful to tell us that it's a stroke, not a mimic, and to avoid mistreatment opportunities. In prognosis, it tells us what's dead versus salvageable, at least a fairly good estimate in many cases. And then in treatment selection, this late window thrombolytics is really where we still have evidence that that is the way to select patients who benefit. In some of the other areas, particularly thrombectomy, there is less requirement for it, although people in the real world who wouldn't have fitted into trials who have frailty and comorbidity and more marginal risk benefit, it can be very helpful to have the prognostic information from a CT perfusion. As I mentioned, CTP is a lot easier to access than MRI, perfusion-diffusion mismatch. You don't have to worry about metallic implants and agitation, other things that make MRI difficult. And if you're doing it routinely, as we do for all patients across Australia, then you get familiarity bringing speed and quality. So I'm going to spend a bit of time talking about the Extend trial and the meta-analysis we did with ECAS4 and Epithet. The Extend ECAS4 Epithet patient population were 4.5 to 9 hours from their last known well time, or wake up within 9 hours of the midpoint of sleep. So if you went to bed at 10, you wake up at 6, the midpoint's 2, and then you would have 11 hours from that point. So around 11 a.m. in the morning was when we started missing out on our wake-up stroke patients. And if you take it from the last known well time, that's approximately a 16-hour window, so very similar to diffuse 3. The majority of these patients had a large vessel occlusion, an ICA M1 or proximal M2, very retrievable thrombus, but this preceded the thrombectomy trials, Dawn and diffuse 3, so none of the patients actually had thrombectomy in these trials. CT or MR perfusion mismatch was used. ECAS4 was almost entirely MR perfusion, as was Epithet, and Extend was predominantly, but not exclusively, CT perfusion. We found when we switched from MR to CT, we saved over an hour in the door-to-needle time. The studies were all placebo-controlled versus alteplase, double-blind, and the primary outcome was MRS01. The mismatch criteria we used in Australia were a little different, a little more lenient, if you like, compared to diffuse 3. So we only required a ratio of 1.2 and a volume of 10 versus the 1.8 and 15 mils that was used in diffuse 3. We had the same ischemic core threshold less than 70 mils, and the core threshold was the relative cerebral blood flow less than 30%, or the ADC less than 620 if we were doing MR. So it's a very different paradigm to the wake-up diffusion flare mismatch that I'll come back to. So there was a very clear-cut benefit in those who had automated perfusion mismatch, and this was using the Rapid software at the 0-1 level, and the odds ratio was over 2, absolute benefit of 10%, which was unadjusted, compared to TPA 0 to 3 hours, very favourable both in absolute and relative terms. The mortality had a trend towards increase, but when you look at MRS 5 and 6 together, there was no trend for harm. So what was interesting about the meta-analysis was the patients who didn't have automated perfusion mismatch had no hint of benefit, in fact, a signal of harm. And these were patients who predominantly had small mismatches. So particularly in ECAS4, they were looking at the MR visually rather than putting thresholds around it, and people were often a bit over-optimistic about how big the perfusion lesion was compared to what we would have had we put a Tmax 6 threshold around it. And there are a few unrecognised large cores as well that people hadn't appreciated visually. And the combination of no mismatch or large core was not good for the patients when they had alteplase. Now, there was, as I said, a majority of patients, around 64% of patients who had a large vessel occlusion. The ones who didn't have a large vessel occlusion were what we would call MEVO, or distal medium vessel occlusion. They were predominantly the more distal MCA occlusions, but also PCA, ACA, and SCA. We didn't have lacunes in these trials because lacunes won't meet the perfusion mismatch definition. You can see that in general there wasn't any heterogeneity between MRS01 with or without vessel occlusion and those without vessel occlusion, large vessel occlusion, sorry. had a very clear benefit of alteplase. So certainly this group who are still not eligible for thrombectomy even today benefit and should be offered alteplase or tenecteplase in my opinion. And the ones with LVO are a little trickier. Depends how quickly you can get them to the thrombectomy because we obviously have the timeless trial I'll come to shortly. Diffusion flare mismatch is a different philosophical paradigm here. Rather than identifying salvageable tissue as we are with perfusion mismatch, we're trying to identify patients where we don't know the onset time clinically, but the imaging tells us it's likely to have been recent. And if you have a diffusion lesion without an established flare lesion that indicates increased water content, then those patients are likely to be within 4.5 hours of onset, even though you can't tell that clinically. And these patients clearly also benefit. The Wake Up trial had a relatively mild stroke population with a median stroke scale of 6. And obviously there are some logistic challenges of getting an MRI acutely, but this paradigm does have that potential advantage of treating some lacuna stroke in whom you don't have established flare changes, but the diffusion lesions there. And this sub-study suggested that those patients probably benefit as much as those with a vessel occlusion. We're now going to move on to tenecteplase. Obviously, there is now evidence from meta-analysis that tenecteplase is not just non-inferior but superior to alteplase, with a number needed to treat in the range of around 20. And we have this study called TRACE-3 that I was involved in China that looked at patients with large vessel occlusion who did not have access to endovascular thrombectomy. And there was a very clear-cut benefit of tenecteplase versus standard care in this group. And you can see really the results are very consistent with Extend. They were mismatch selected patients using CT perfusion. So one comment I did allude to earlier is that the non-contrast CT is really important. There were a few patients who had protocol violations with established CT hypodensity, and 5 out of 9 of those patients had a symptomatic hemorrhage. So we really do need to carefully evaluate the non-contrast CT and not just look at the CT perfusion, because in this late time window you can have established hypodensity outside the region of the current perfusion lesion. We need to consider that for the safety of these patients. The other thing I'll just point out is that next week at ISC there will be another trial performed in China, this time the HOPE trial using alteplase 4.5 to 24 hours. It's well worth looking out for the results. The question of what we do when we're going to do a thrombectomy was addressed in the IRIS trials. These were 6 trials that looked at non-inferiority of alteplase versus direct EVT. And you can see that there wasn't a great deal of difference overall. There was a slight trend favouring having bridging thrombolytic on board. And when you look at some of the sub-analyses, that's a little stronger. So the the as treated analysis did actually reach significance on the ordinal MRS for having bridging thrombolytic. There's this 2% difference in MRS02. There was improved reperfusion at the end of the thrombectomy, and there was a slight increase in early recanalization at the initial angiogram, so not needing the thrombectomy. These are numbers that are obviously a lot smaller than what we saw in Extend IOT&K, where we had a 20% rate with tenecteplase and a 10% rate with alteplase. But the time to treatment, the amount of time that the tenecteplase had, or the alteplase in this case, had to work was much shorter. It was about 25 minutes versus 45 minutes in Extend IOT&K. Symptomatic hemorrhage, which was the concern, that people thought we might reduce hemorrhage by dropping the lytic. It was a 1% statistically non-significant increase when you had alteplase on board, but that was entirely offset by a 1% statistically non-significant reduction in mortality when you had bridging thrombolytic. So I can't really make an argument based on symptomatic hemorrhage or mortality that direct EVT is better. And as I said, there is some suggestion that overall functional benefits are improved. The other thing to consider are the subgroups. Is there a subgroup who benefit? The most interesting ones are the time. So certainly earlier delivery of thrombolytic, and I'll show a separate study on this. The ones who got lytic early after onset did benefit more. And then the ones who had an extensive non-contrast CT hypodensity, so in aspects of 0 to 5, it's not statistically significant. It's a small subgroup, but there is a hint that perhaps people with a lot of non-contrast CT changes might be better off just going direct to thrombectomy, and that's something that requires more study. Another interesting subgroup were the ones who had a tandem occlusion, many of whom needed a stent, and that was another group where they often need antiplatelets, and people thought it would be safer not to have thrombolytic on board, and that really wasn't borne out in the data. There's no interaction whatsoever with the need for stenting that we can see in these data. Here's a sub-analysis looking at time in more detail, and you can see that within 2 hours and 20 minutes of onset, there is definitely a benefit of alteplase bridging prior to thrombectomy. Beyond that, the confidence intervals cross 1, and you can see that out to over 3 hours. So essentially our standard window for thrombolysis, there is likely to be a benefit of alteplase and probably even more benefit of tenecteplase, and the earlier we can get it in, the better. Now, I couldn't talk to the Houston audience without mentioning mobile stroke units. Of course, this is our Melbourne mobile stroke unit. It's been on the road since 2017, and we can do a non-contrast CT and an intracranial CTA, as can you. But it is difficult, and we don't treat our wake-up stroke patients currently and our beyond 4.5 hour time window because we don't have really a usable perfusion scan. You can get a 1 centimetre slab that we don't bother doing. So this is something that would be good to study, but we don't currently treat patients with unknown onset or beyond 4.5 hours on the mobile stroke unit. So let's talk about EVT and the extended time window. With a timeless trial, was a very well conducted placebo-controlled double-blind study where you had patients with ICA M1 and M2 vessel occlusion and mismatch on perfusion, 4.5 to 24 hours, and they randomized to tenecteplase or placebo prior to, in most cases, 87% of them had a thrombectomy. And the median time from giving the tenecteplase to thrombectomy was 15 minutes, so very fast. And that is one of the problems with interpreting the results, is that many of us have a lot longer gap, or if we're transferring a patient, that's a very different scenario to a 15-minute dwell time. So using the standard rapid perfusion mismatch criteria with the diffuse slightly stricter thresholds here, and also excluding hypodensity on non-contrast CT greater than 1/3. So it did not show a benefit of tenecteplase when EVT was about to be performed, noting that the lytic to puncture of 15 minutes was even shorter than those IRIS direct trials at 25 minutes. You can see that there were trends that looked favourable, particularly at MRS01. And if you look at the subgroup with MCA occlusion, that did nominally reach significance. The time relationship here was a little confusing, in that people who were having the tenecteplase as they started the procedure were the only group that seemed to have a trend to benefit, and M2s paradoxically didn't seem to benefit, and that's probably because there was a bit of heterogeneity in who got thrombectomy and who didn't within that M2 group, and it became imbalanced. So there's the M1 subgroup with a nominally significant shift in MRS and MRS01 that looks quite positive. This needs another trial really to see if a more selected population, preferably with a longer dwell time, could benefit from a bridging thrombolytic approach in the late time window. So with Timeless, it was very challenging to do a placebo-controlled regulatory trial in primary stroke centres. There was a lot of effort put into trying to recruit primary stroke centres, but only a tiny population of the trial were recruited there. So US stroke centres, primary stroke centres rarely do CT perfusion, which is unlike our Australian context, which was another challenge. And there are also the issues that we had with direct EVT trials, because they only apply to direct presenters to an EVT capable centre when in majority transferred. And the trial design biased against the lytic, because in all these trials, EVT is standard care. That's going to proceed without delay, but the intravenous component is delayed until the patient's identified as a candidate, consented and randomized, which means that you prolong the onset to lytic time, which, as I showed you in that Kai's marker analysis from IRIS, the earlier you can give the lytic, the more effect it has on beneficial outcome. And you also shorten the lytic to puncture, or the dwell time, which means you're not going to get as much chance to reperfuse the brain before the thrombectomy. So for all these reasons, trials, the direct trials and Timeless for that matter, bias against effect of the lytic. Now, of course, we now have the issue of large core thrombectomy throughout the 24-hour window, and those 6 trials have shown a very clear benefit of thrombectomy in those patients, particularly on the Rankin 03 independent ambulation kind of outcome. Independent functional outcome clearly is not as common with large core patients, but they still have an absolute benefit versus medical management. So in terms of intravenous thrombectomy in intravenous thrombolysis in large core, by definition, these patients will mostly have a large vessel occlusion, and EVT will be the definitive therapy. And if you've particularly got an ICAT occlusion, which is where a lot of these large core patients have their blockages, IVT has limited efficacy in that group. Most of the alteplase trials excluded greater than 1/3 MCA hypodensity, and so patients with very low aspects that went into these trials probably wouldn't be our standard population for IVT. And in the extended time window, of course, we excluded patients with greater than 70 mil core, and the majority in trials like Epithet, ECAS4, Extend, and Trace3 had cores less than about 30-35 mils. So we know in the large core trials that 20 to 40% did have IVT, and they would mostly be in the early time window when there are not established non-contrast CT changes. The risk of symptomatic hemorrhage probably relates to that extensive CT hypodensity, indicating blood-brain barrier disruption, and we don't withhold thrombolysis from someone in the early time window with a large CT perfusion core that's not evident on the non-contrast CT yet. In the context of immediate EVT, the IRIS meta-analysis would suggest those very poor aspects groups are probably better off with direct EVT, but it's a small non-significant subgroup. If it's going to be delayed, we would, as I said, treat if it's 0 to 4.5 hours and it's just a perfusion core rather than a non-contrast CT core. Some of the key messages about IV thrombolytics is that there are no definitive benefits of alteplase or tenecteplase beyond 4.5 hours in patients using non-contrast CT. Perfusion mismatch up to 24 hours and flare diffusion mismatch are the proven paradigms. We have the importance of non-contrast CT that I've emphasized a number of times for safety, and we now have data that tenecteplase is convincingly non-inferior to alteplase overall 0 to 4.5 hours and superior in meta-analysis. And the data with Trace3 suggests that that safety profile and efficacy is preserved out to 24 hours. We have a dose of tenecteplase of 0.25 milligrams per kilogram that's well established, although there are some plans to trial an intermediate dose of 0.18. And mostly, as you know, the benefits of tenecteplase are practical in that you can give a bolus immediately with no concern about bolus infusion gaps or infusion interruptions that would destroy the pharmacokinetics. There's also the safety advantages of using a single thrombolytic for all stroke patients, so to reduce confusion about dose. So the Trace3 TNK data are therefore very helpful in reassuring us that we can go out to 24 hours with the same agent and not have one agent for the standard window and one agent for the extended window. I hope I've convinced you that bridging tenecteplase before endovascular thrombectomy is beneficial, at least within the first few hours. And outside comprehensive centres, I would still be using it 4.5 to 24 hours, although there are trials testing that. But if you have an expected delay of an hour or two or more from when you could give a lytic in a primary stroke centre to when they're going to arrive for a thrombectomy, we certainly use that window in Australia. So what about the practicalities of implementing perfusion imaging? As I said, in Australia, we do it in all our primary stroke centres as well as our comprehensive stroke centres. Even tiny bush hospitals run by family physicians are doing CTP routinely. And we have a number of reasons for that. Diagnostic accuracy is probably one of the main ones because stroke versus mimic is not always that easy, and the staff at the bedside vary in experience. And if you're doing telestroke, it's incredibly helpful to have that verification of the exam that you're being told about and what you can partially see over the camera with some imaging to prove that it's actually a stroke. So through accurate diagnosis, you avoid missed treatment opportunities, you avoid delay due to diagnostic uncertainty. It's very easy when you see that left ACA perfusion lesion to know that the right leg weakness is a stroke and not some orthopedic problem, and that is not a migraine but a right PCA occlusion, and that's an MCA occlusion that's caused the patient to be a bit confused and uncooperative perhaps. And there's someone who needs a thrombectomy, and there's an ICA occlusion that definitely needs a thrombectomy. So we can sometimes also make a positive diagnosis of mimics. This is hyperperfusion, where you've got reduced Tmax and increased cerebral blood flow and volume after a seizure. So that can be very helpful. In terms of diagnosis, we also have the improved accuracy and speed of interpretation of vessel inclusion. Here is an example of someone with a MEVO. When you look carefully at the non-contrast CT, if you look at that vessel I've highlighted in the green circle and follow it through, you can see that it disappears about there. But trying to pick that prospectively can take a few minutes and a few reconstructions in different planes, whereas if you look at this CTP, you know exactly where to look for the vessel occlusion. You know that they've got a distal median vessel occlusion. This is also an example of someone with an M1 occlusion. They're within time window. They've got a good non-con CT. It would seem to be a straightforward case for thrombectomy, but when you do the perfusion, actually it's a PCA acute occlusion and an MCA chronic occlusion, and sticking a wire down the chronic occlusion won't do the patient any good. And there's the follow-up imaging to show it was purely PCA. So you can save yourself, particularly in environments where intracranial atherosclerosis is quite common. These patients are not surprisingly rare, and you can save yourself some trouble by learning what's acute and what's chronic by the degree of perfusion compensation. We often talk about lacunes as not meeting perfusion mismatch, but you can often identify a lacune if you have a high quality perfusion image. Here's an example of someone with increased MTT in their left thalamus, matching with a reduced CBF and matching very nicely with the subsequent MRI. And about 50% of the time, with knowing what you're looking for and good quality CTP, you can pick lacunar infarcts based on their perfusion lesion. Prognosis is something that we also find perfusion really helpful for, talking about families, about likely outcomes and patient preferences. We've got to remember that patients over 80 were underrepresented in the large core trials, and they do have frailty and comorbidity that can make the risk benefit a little different. These, trials did not include patients with a rank in anything more than 1, and they excluded life-limiting comorbidities. So in reality, we have a much sicker patient population where we need to think about what's the realistic probability of getting this patient what they would regard as an acceptable outcome. What's the likelihood of speech or motor recovery is often something we're trying to counsel patients about. What's the need for likelihood of a need for a hemicraniectomy after a thrombectomy? So you can see that core volume is incredibly strongly prognostic. There is still a treatment effect out to at least 150 mils, it would seem from these data, but it's one of the strongest prognostic factors. And if you combine it with age as a surrogate for frailty and the time you expect to get the artery open, whether they're in your hospital or someone else's hospital, then you can make quite good predictions about whether you're likely to get back to an acceptable outcome, in this case, Rankin 0.3, independent walking. You can see that unless you're very young and robust and fast, if you've got a core volume of 150, you're unlikely to get back to independent walking. And that's useful to know. Now, there are a lot of discussions about the caveats of CT perfusion. Basically, CTP is a snapshot of the hemodynamics at the time of acquisition, and therefore can be fooled if the hemodynamics have changed. So it relies on relatively consistent hemodynamics between onset and the time of imaging, and particularly in this extended time window that we're talking about, things may have changed. The clot may have migrated distally or fragmented. There may have been ischemia outside the current perfusion lesion earlier on that's still very relevant to know about. The relative CBF of less than 30% of normal brain works well most of the time. There are situations where if you are super fast and super early, you may salvage a bit more than that. And it's also about the qualitative appearance, as I'll show you in some cases shortly. There are suggestions that less than 20% may be better for people who are ultra early. In my experience, generally it's the white matter that you salvage if you salvage tissue, and that's not generally what you see with less than 20%. Poor collaterals give you sharp borders to the perfusion lesion, and that's something that can be useful to look at. CBV reduction is also very specific for irreversible injury, so if you have congruent CBV and CBF, you can be much more confident that the tissue is already irreversibly injured. And very delayed Tmax is also indicative of very severe ischemia. So here's an example of someone with a very sharp demarcation between the left MCA, it's actually an ICA occlusion, so there's some involvement of the right ACA as well in this patient. The CBF thresholds, you can see here 20%, 30%, 34%, 38%, all of them are very large core. So you can be pretty confident that there's not a gradient that's allowing some flexibility in what may have been injured. The CBV is also super low and super large lesion. So you can be very confident, as is the Tmax greater than 10 seconds. So this patient has, as you can see from their sort of collateral here, no collateral, no blood supply to that hemisphere. You can be very confident in this case with the sharp borders, the congruent CBF, CBV, and Tmax that this brain is not going to be salvageable, even if you get the artery open immediately. Whereas this patient has a CBF 30% core of 88 mils, so they would fit the large core definition, but the 20% threshold is very small, only 7 mils. The CBV thresholds are in the 20s or 30s, and if you look at this, there is a definite gradient across the lesion. So this is somewhere I'm much less confident about how much damage is going to have been done if you get the artery open quickly. And here's their 24-hour scan, and you can see that the area with reduced CBV, which was that anterior temporal lobe and this little frontal region here, has definitely infarcted, and the rest of the brain doesn't look too bad. Now, there are, less sulci there. There is some blurring. We've got to remember after EVT, there is always some contrast staining, even when it doesn't look obvious. There will be some contrast staining in this area. And if we'd done an MRI, which unfortunately we couldn't in this case, there would be cortical diffusion restriction throughout some of this MCA territory. But the reality is that some of the tissue has been salvaged and the patients responded clinically with a stroke scale dropping from 20 to 2. So this is what some people would call ghost core, and there are a number of problems with that concept. Basically, if you're going to call ghost core, you should be doing an MRI for a start, not a CT, which is insensitive, or at least a dual energy CT that cancels out the contrast and shows you what's really hypodense. And then you'd want to be doing that MRI beyond 24 hours, because within 24 hours, there's often temporary reversal of the lesion that then comes back later. And as I said, usually when you salvage something, it's the white matter that you salvage, not the grey matter. So you'll still see cortical diffusion restriction. But fundamentally, I think we need to appreciate that brain is not dead or alive. There is a gradient of injury from selective neuronal loss through to full tissue thickness infarction and liquefaction. And that's not really accounted for by our dichotomous view of infarct volume. So what about time and delay with perfusion? It's often criticized, and the reality is if you're parallel processing, you can lyse many patients on the basis of the non-contrast CT, and with tenecteplase you can slip it in on the CT table between sequences as you're setting up for the CTP. But otherwise, if you're uncertain about the diagnosis or it's an extended window case, you'll have the CT perfusion in a couple of minutes to guide your decision making, and it's minimal delay. You can call a neurointerventionist on the basis of seeing a hyperdense artery on the non-contrast CT, but if you don't see that, you'll have the large vessel or median vessel occlusion visible on the CTP in a couple of minutes. Could we do this without perfusion imaging? Well, I've shown you the STTC and twist experience that would suggest you can't, and the patients without automated mismatch that didn't benefit and extend an ECAS meta-analysis. But we probably could identify some patients who are highly likely to have perfusion mismatch based on a non-contrast CT and a vessel occlusion. If you have minimal non-contrast CT damage and an M1 or an M2 occlusion, you'll almost certainly have perfusion mismatch, with the one caveat that you might be super early after a wake-up stroke or an unknown onset when that non-contrast CT change hasn't had a chance to develop. But if you are that early, it probably doesn't matter. So it's probably an idea that's worth trialing. There are some plans to trial this approach. It would be a good approach to trial on a mobile stroke unit. It would be a good approach to trial in low resource areas, but that kind of approach would exclude a lot of patients with less perfect non-contrast CT or a more distal occlusion who would have perfusion mismatch and who would benefit based on our extend and epithet data. So future developments, Beyond macrovascular reperfusion that we mainly talk about, there is this idea of microvascular reperfusion that's being studied in multiple trials of intraarterial lytics after thrombectomy. There's adjuvant thrombolytics. Obviously, we've not had success with the most trial of argatroban or eptifibatide, but there's lots of other potential adjuvant agents under active investigation. Cytoprotection anti-edema are still under investigation, and this is just a review we did recently looking at some of these targets, particularly von Willebrand's factor, NETs, and trials like SISTER and RAISE that you will have seen around the States going on at the moment. So to summarize, reperfusion therapies with thrombolytics and endovascular thrombectomy really have transformed our outlook for patients after ischemic stroke. They are time critical. I've been talking about extended window here, but it's great if you're unavoidably delayed in presenting, but the proportion eligible is lower. We really do want to be focused on getting patients treated as quickly as possible and optimizing our systems of care to deliver that. I think we can now be in a position where we should be giving tenecteplase to all eligible patients with a disabling deficit. I didn't talk about mild stroke, but if you haven't got a disabling deficit, there isn't a benefit of lytics based on multiple trials now. Up to 24 hours, we're using CTB-based selection beyond 4.5 hours, with the caveat of immediately accessible EVT in the extended time window. I think we need more data there, but Timeless would suggest that's not somewhere that there's a huge benefit of adding a lytic. Thank you very much for your attention.